This chapter is on medication for psychological or mental disorders. This is kind of an interesting area. This is what a psychiatrist would typically do. So they prescribe medication for psychological disorders, psychiatric disorders. It's also a field called psychopharmacology. We can use therapy to treat psychological disorders, but we also have medications that are available, and some of them are quite powerful and can treat serious mental illness. None of these medications are going to cure any of these disorders. They're targeting the symptoms of the disorder, so they can improve somebody's functioning. Sometimes they can alleviate the symptoms so somebody is back to their baseline level of functioning. But even though, like, we have antidepressants, somebody might take that and they're not depressed at the end of their treatment, it's not necessarily the medication that cured that disorder. It's a little different than the regular medical model. We're treating symptoms, not really disorders. And the use of medication is quite controversial. And all medications have side effects, not just some. Some are very serious side effects. We'll watch a commercial later in the class where there's a list of side effects, but a lot of times it's even death. So the medical model views mental illness as a type of biological disorder or dysfunction. And I personally like the biological model in conceptualizing psychological disorders, but it has been widely criticized. So the first step in diagnosing a psychological disorder is really to determine what is abnormal. What does that mean by something being abnormal? Many of you may have taken abnormal psychology by this point and know that there's something called the DSM, or the Diagnostic and Statistical Manual, that has all the diagnoses in it. But what constitutes abnormal behavior? Like, I like to gamble a little bit. I'll go to a horse track once in a while, but I go maybe, like 4 times a year, and I might spend $50 every time I go. Is that abnormal? Probably not. If I go every single day of the week and spend my entire paycheck, you might consider that abnormal behavior. So there's different ways that we could think of it. It could be something that is statistically rare, something that causes the individual distress, something that causes other people around that person distress, something that interferes with somebody's ability to go to work, to have relationships with friends, family, significant others, and the ability to have fun. So that DSM gives us a standardized methodology of diagnosing psychological disorders. It's basically like a psychologist's handbook. You go through there, it has a list of symptoms, and if somebody meets the criteria for a specific disorder, that's how we make the diagnosis. With psychological disorders, there's no blood tests, there's no laboratory tests, nothing like that. It ends up being very subjective, and a lot of times based on clinical judgment of the person making the diagnosis. What we do is we divide mental disorders up into different groups. So we have anxiety disorders. Anxiety disorders are characterized by fear. Fear is normal, but when fear is out of place, it is not an appropriate response to a stimulus, or it is out of proportion. That's what we call anxiety. So people will have excessive fears, worries, or will avoid certain situations. Panic disorder, phobia, obsessive compulsive disorder, generalized anxiety disorder, those are all different types of anxiety disorders within this category. Psychosis is a different type of disorder. So someone that is psychotic has lost touch with reality. And the hallmark symptoms of psychosis are hallucinations, which is a sensory experience in the absence of a stimulus. or delusions, which are firmly held beliefs that will not go away even if given evidence to the contrary. So a firmly held false belief system. Those two things are the characteristic symptoms of schizophrenia. Now, schizophrenia, sometimes we divide the symptoms into positive and negative symptoms. Those would be positive symptoms, things that are there that are not normally there in people, so we add something. Negative symptoms would be like, flat affect or mood, decreased hygiene, stuff like that. Mood disorders include major depressive disorder, bipolar disorder, and dysthymic disorder. So here we're looking at a manic episode or a depressive episode. A manic episode is like the opposite of a depressive episode. Major depression sometimes carries a risk of suicide. Sometimes somebody with bipolar disorder will, not sometimes, they will cycle between manic episodes and episodes of depression. So we've developed these drugs, but the development of the drugs really started, the drugs have been around for a while. I mean, we've had psychiatric medications since the late 1800s. Probably even before that. I mean, people have been using lithium for a long time. But in the United States, they first started gaining widespread clinical use in the 1950s. Before that, psychiatric patients were hospitalized in large state hospitals, and the treatments that they were given, sometimes it was psychotherapy, but they also used more like sedatives. So like chloral hydrate is a sedative. That's been around for a long, long time. They use that. Other therapies like insulin shock therapy, they would give people huge doses of insulin to get them to have a seizure. Lots of different things, but none of them really worked very good. Then, with the introduction of the antipsychotics in the 1950s, it started this huge revolution in the mental health care field. There's a picture of electroconvulsive therapy, or ECT. That therapy involves passing an electrical current through the temporal lobes of the brain. So the antipsychotics are a category of drugs. And what those do is help with psychosis. So those are typically prescribed with people with schizophrenia. I mean, sometimes people that are in a manic episode of bipolar disorder. This is an old antipsychotic. We call these conventional antipsychotics or first generation antipsychotics. It's called Haldol. Now, the antipsychotics are typically pretty safe. However, they have some pretty profound side effects, and these side effects can become permanent. They resemble like Parkinson's disease. They're movement disorders, so we call those extrapyramidal side effects or tardive dyskinesias. Here's a video of the tardive dyskinesias. Watch these patients' faces. If somebody's taking antipsychotics and they start to have these side effects, unfortunately, they're going to be permanent.
Tardive dyskinesia is characterized by involuntary, repetitive movements of the extremities, as well as grimacing, rapid blinking, and impaired movement of the fingers. There is no known treatment, and the symptoms are rarely reversible. However, in some patients, the symptoms may lessen or resolve when the drug is stopped.
So that's not good. And you can get tardive dyskinesias with lots of different antipsychotic drugs. There's a new generation of antipsychotic drugs, and they have decreased risk of tardive dyskinesia and extrapyramidal side effects, but they can still happen. Those are called the atypical antipsychotics, or second generation antipsychotics. And they're still good at reducing the symptoms of schizophrenia. They're really not as good as some of the conventional ones, but they do have less severe side effects. That said, they still have really severe side effects. So you can get hyperglycemia, that's blood sugar levels, hyperlipidemia, hypercholesterolemia, weight gain. I mean, it's not uncommon for people to put on like 60, 80 pounds when they're on an atypical antipsychotic. There's an example of one there, Abilify. You probably see commercials for that. Okay, now, the mood disorders. You've got 3 major categories of drugs that are used to treat the mood disorders. You have the monoamine oxidase inhibitors. Monoamine oxidase is an enzyme that breaks down the monoamines, which are like dopamine, epinephrine, serotonin, different neurotransmitters. It's based on their structure. The tricyclic antidepressants, and the selective serotonin reuptake inhibitors, or SSRIs. There's Elavil. That's amitriptyline. That's a tricyclic antidepressant. Selegiline here. That is a monoamine oxidase inhibitor. Now, the idea that we have these drugs to treat depression brings up the idea of a chemical imbalance. And I want to talk about this a little bit because this is like kind of misconstrued. When people talk about a chemical imbalance, you think that you can go into the brain and measure neurotransmitter levels and figure out which one's out of balance and then treat the disorder based on that. That's not really true at all. I mean, everybody has their own like set points, and it's kind of hard to say what's out of balance or what's in balance. The reality is that when you take a drug, a psychiatric drug, what you're doing is then creating a chemical imbalance. Here's a list of tricyclic antidepressants: amitriptyline, diazepamine, doxepine, imipramine, nortriptyline, protriptyline, and triimipramine. You're not really going to see these used too much in the United States. They're actually kind of easy to overdose on. Dorothy Dandridge, a famous actress, overdosed on tricyclics. Nick Drake, a famous musician. These are the MAOI inhibitors. We talked about selegiline. You don't really see these used clinically too much either. And here's the SSRIs. These, I'm sure you've heard of these. Celexa, Lexapro, Prozac, Luvox, Paxil, Zoloft are the brand names. The drug names: citalopram, S-citalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. Those are all really common antidepressants. I mean, estimates are that up to 10% of the population over the age 12 takes an antidepressant. So how do the SSRIs work? Well, what we have here is, where is it? They're not really showing it here, but right here on the presynaptic neuron would be something called a reuptake transporter, or a reuptake pump. And what the SSRIs do is they block that pump from working. So selective serotonin reuptake inhibition. If you can't take the drug back in to be recycled and repackaged, you leave more serotonin in the synapse. And that theoretically increases binding here at the receptor sites, which increases serotonergic activity. So antidepressants typically work by increasing serotonin or norepinephrine. It's another neurotransmitter. But there's a lag between the time you take the drug and the time that the drug actually starts working. So I'll talk about that in part 2.